In this module, we will discuss hearing and hearing disorders. We will talk about the anatomy and physiology of the ear. We will also talk about sound and the transmission of sound. And then we will talk about the disorders of hearing, how you treat those and diagnose those. Let's first talk about the transmission of sound. In order to understand the anatomy and physiology of the ear or of hearing, you must first understand sound and how sound is transmitted. Sound is characterized by a back and forth motion or transmission of energy from molecules to other molecules. This movement of sound can be depicted as a waveform. So if you look on page 238, you can see pictures of this waveform. It's not actually a transmission of matter or a transfer of matter. Transmission of sound is actually a transfer of energy. So you can see a picture of this on 238 and 239. Let's now talk about some physical properties of hearing. The first one we'll talk about is frequency. And frequency can be described as the number of back and forth movements of an air molecule that occur within 1 second of the sound. So if you look on page 239, you can actually see frequency being measured. It's actually measured in what's called hertz. You can see the symbol for hertz here in front of you on the slide. The perceptual correlate of frequency is pitch. So we can actually hear pitch. We know when something's high or low, but we can't measure that. So in order to measure it, we have to use the specialized computer equipment, microphone, software, and then we can measure the actual frequency, which are this wave-like form of hearing. And another physical property is what's called intensity. And intensity is associated with the amount of sound pressure that occurs as a result of the collision of air molecules. So it's that pressure and how much pressure is resulting in this transmission of this energy. And its perceptual correlate is loudness. So we might say something is really loud or is really soft, really quiet. But we can't measure that. But we can measure the intensity. So we measure that in what's called decibels. So oftentimes if I'm doing a hearing screening, I'm checking hearing at different frequencies, and I'm checking it at different hertz. I put it on different hertz, and then I also am checking the intensity, so I'm putting it on different decibels. So we're trying to check and see if hearing is adequate. You may do a screening, and then also audiologists will measure that in a sound booth. They'll do further assessment and will test the frequencies and intensity even further. So if you look on page 241, you can see that decibels can range anywhere from 0 to 120. 120 is like a concert, like super loud. And but the only way we measure that is through decibels. We can say, "Ooh, this is really loud," but the intensity is actually at 120 decibels. So I have a picture here of some frequencies and also the decibels where certain environmental sounds are happening. And if you look at the top there and see that kind of purple wave, it almost looks like a banana. That's often called the speech banana. Those are where sounds are produced. At those frequencies, you can see which sounds are the higher frequency sounds. You can see the sounds that are the lower frequency sounds. And you can see about where conversation is taking place, like at what decibels people are saying certain sounds. You can also look again on page 241 and see the sound of a refrigerator hum, the sound of tractors rock concert, conversation, iPod. And so I would take a look at this in front of you and the chart on 241 and kind of get an idea of where different sounds are being produced. Let's now talk about the anatomy and physiology of the ear. I encourage you to read about this in your book so that you can understand it in more depth, but I'll touch on it here. The ear has 3 parts: the outer ear, middle ear, and inner ear. The outer ear is made up of the auricle or the pinna and also the external auditory canal. Research shows that one can hear without the auricle or pinna. So this auricle and pinna actually doesn't help with hearing. So people can hear without it, but it does help with the localization of sound. So we do know that its shape helps localize sound. It helps actually transmit higher frequency sounds because of the shape that it has. So it is helpful in hearing. It's not just there to hold your earrings. We know that the external auditory canal is a closed-end tube, which is part of the, if you look here in the picture on page 242, it's also here in front of you on the slide. That auditory canal is actually the place where cerumen or wax is produced. And earwax or cerumen helps prevent dirt and foreign bodies from reaching the bony portions of the ear. It actually serves as protection. So the auditory canal eventually reaches what's known as the tympanic membrane. So as the sound is traveling down the external auditory canal, it then hits the tympanic membrane or the eardrum. And this is in the middle ear. So the middle ear is air-filled, and it's in the hardest bone of the body, which is the temporal bone. It connects the outer ear to the middle ear, to the inner ear, and it converts that acoustic energy of the sound pressure wave into mechanical vibrations. So it takes this acoustic energy and then it turns it into mechanical vibrations. So there are 3 tiny little bones, the tiniest bones in the body, that are part of the middle ear, called the malleus, the incus, and the stapes. And the malleus is actually embedded within the tympanic membrane. And sound pressure waves in the auditory canal cause the tympanic membrane to vibrate. As it vibrates, the malleus vibrates, and then the ossicles result in mechanical vibrations and transmit sound toward the inner ear. So then the inner ear has 2 important components. The semicircular canals are responsible for balance, movement, and vestibular function, so help determine the position of our body in space. And then the second component of the inner ear is the cochlea, and you can see it here. It looks kind of like a snail, and you can also see it on page 244. So the function of the cochlea is actually explained really well on page 244. But the main thing you need to know about the cochlea is it's a closed system filled with fluid. And the stapes pushes inward on this, what's called the oval window, and causes a wave-like motion in the cochlea. So you can think about it as uncoiled. And as the wave-like movement caused by the stapes that was in the middle ear pushes against the oval window, it results in movement inside the cochlea. And so this mechanical energy, so it was acoustic energy, it turns into mechanical energy, and now it's turning into hydraulic energy. So it results in movement because there's fluid here. So it results in movement of the hair cells, and this energy within the cochlea is liquid. And so then the spinal movement of the energy is converted into a neural signal or bioelectric energy, and then it goes to the acoustic nerve. So if you think about it going from the outer ear, which is acoustic, it kind of goes in, and it's goes through this air-filled space, and then it's turned into mechanical energy where these little bones start moving, the three bones, the stapes, the incus, the malleus. And then, I'm telling you in a very simple way, but I encourage you to read it. And then it's transferred into hydraulic energy, which is in the cochlea, so this liquid energy. And then it's converted into bioelectric energy, or a neural signal, when it goes to the brain. So that's the molecules kind of transmitting this energy. So think of it as energy being converted into different forms of energy. Let's now talk about what happens when there's a breakdown in this transmission of energy. Typically, we talk about hearing loss divided into three categories: conductive hearing loss, sensory neural hearing loss, and mixed hearing loss. Conductive hearing loss occurs as a result of a problem with the outer or middle ear. So anything that interferes with sound moving through the system can result in this type of hearing loss. Atresia is a condition where the ear canal has failed to develop, or damage has occurred to the ear canal. This can be because of some trauma, like burns or a syndrome. Atresia of the external ear canal can cause problems with sound localization or hearing loss. Another problem is children often can put objects in their ears, can cause swelling in the ear canal. That can result in conductive hearing loss. Conductive hearing loss does not have to be permanent. Something known as external otitis or swimmer's ear may result in mild conductive hearing loss. It can cause a lot of pain for the patient. This happens when there's infected water trapped in their ears. It's often hard to test these people who have this, because this external otitis, because it might be very painful to put earphones on the patient's ears. Some people may produce large amounts of wax or cerumen, and when they try to clean out their earwax, they may push the earwax further into the canal, and this can cause a small plug, and that prevents sound transmission. So that may cause some conductive hearing loss, and the physician may have to remove that wax. But the most common cause of conductive hearing loss is what we know as ear infections or otitis media. Otitis media is inflammation and fluid in the middle ear. So if you remember, we talked about the eustachian tube as equalizing the pressure between the middle ear and the back of the throat. However, there are a lot of individuals who have upper respiratory infections, sinus infections, enlarged adenoids, and that may cause eustachian tube dysfunction, because the eustachian tube is swollen or blocked and it's unable to equalize pressure. So the pressure within the middle ear cavity may become less than the pressure in the throat or the outside environment. So the tympanic membrane is retracted or pulled inward. And as long as the eustachian tube remains closed, the negative pressure within the ear will result in fluid being drawn out of the cells lining in the middle ear. So the fluid is coming in. And initially, it's germ-free. It can still cause problems because the ossicles may not be able to move. But at this point, it may just cause problems because you might not be able to hear. It might sound like underwater, or you might not be able to fully hear the TV, or conversations kind of sound muffled. If the problem persists and light and oxygen within the middle ear creates an environment for bacteria or infection. So the patient may, if you can see with babies, you see this a lot in little kids, they develop what's known as ear infections. And so this fluid has become infected, and they can get a fever and they can have pain. And this infected fluid within the ear continues to increase and push against the tympanic membrane. And ultimately, the tympanic membrane can develop a hole in it because this fluid has pushed against it and it burst. If you look on page 248, figure 11.8 shows exactly what happens in otitis media, the steps, the stages. So a lot of times when children and adults have otitis media, pediatricians or regular doctors will prescribe antibiotics, or they'll treat it with medication. But this happens multiple times, especially when speech and language is developing. Speech and language can be greatly impacted by these frequent bouts of conductive hearing loss. So it's important for a child with many ear infections to possibly see an ENT. They may need what's known as PE tubes, or pressure equalizing tubes. So medication may not always be the right answer, especially if there's multiple ear infections. So I always, the first thing I ask a parent when I'm evaluating a child with a speech or language problem, especially a young child, have they had a lot of ear infections? And if they're like, yes, how have they been treated? And then if I know that they've had frequent bouts of conductive hearing loss or frequent bouts of ear infections and they haven't seen an ENT, then I will quickly make referral. Because an ENT is one who will place PE tubes, and the pediatrician will usually just prescribe medicine. Now, sensory neural hearing loss occurs when there's damage to the cochlea or the acoustic nerve. So this hearing loss doesn't just affect loudness, like conductive hearing loss does. It also affects the signal. So the person's ability to recognize and understand speech sounds and words is affected. So sensory neural hearing loss can be congenital, which is from birth, or acquired, which occurs after birth. So more than 50%, according to ASHA, more than 50% of congenital hearing loss is related to genetic factors. So the parent carrying a dominant or recessive gene for deafness. So a parent who is deaf may carry a dominant gene for deafness, and there will be a 50% chance that the child will be deaf. And if both parents are deaf and they carry the dominant gene, the chances will be higher. When two normal hearing parents carry a recessive gene, then the child has a 25% chance of being deaf. It is interesting to note hearing loss is often associated with various syndromes. Other congenital factors associated with sensory neural hearing loss include prematurity of the infant or diseases at birth, such as rubella, maternal diabetes, etc. Acquired sensory neural hearing loss occurs anytime after birth and throughout the life of an individual. Viral diseases such as chickenpox, mumps, and measles can cause it. Bacterial infections from untreated otitis media can lead to meningitis or an inflammation of the brain coverings and cause hearing loss. Acquired sensorineural hearing losses in older adults is the third most prevalent chronic condition in the U.S. Presbycusis is the hearing loss which is associated with aging. It usually occurs in men in their late 60s, and then a lot of times in women who are a little bit older than that. A second common cause of acquired hearing loss in adults is noise. So have you ever gone to a rock concert and then you've left and you really have to raise the intensity of your voice so you can hear yourself even after the concert is over, because you're there's been a temporary threshold shift. And usually your hearing goes back to normal, but sometimes there can be a permanent threshold shift who've had repeated exposure to noise levels. So my father's in a band, and he has been in a band his whole life. He's still in a band in his 60s. They don't play near as often, but he's still in a band, and we think that he's definitely experienced some hearing loss from always playing that loud music. So there's also noise-induced hearing loss that's a result of working in factories, military, being around guns, loud explosions. So it's often recommended to use external protective devices like headphones. You will see, if you've seen lately, it's kind of the trend for these rockers' wives who've had new infants will have these fashionable earphones on at rock concerts. I don't know if you've seen pictures of this, but it's kind of the in thing to do, which is great because they're protecting their hearing. But I've noticed that it seems to be kind of the in thing to do to put these cool headphones on your infants at these concerts. There's now a growing concern among professionals who work with hearing impaired and deaf that our frequent use of portable music players and earphones has the potential to cause permanent hearing loss. So your iPods, your phones, over time can cause some damage. And sometimes by the time we've identified the hearing loss, it's too late to do anything about it. So just know that your loud music may be affecting your hearing. So that there is a setting on your iPods and on your phones where you can not allow the volume to go up past a certain level, and it's a really good idea to use that. Something called acoustic neuroma is a type of tumor that grows near the acoustic nerve and can affect a person's hearing. Ototoxicity is the damage to the inner ear that occurs as a result of medications that can cause hearing loss. I've heard of this too, or you may have heard of that. It's not unusual for a patient to experience a severe medical condition for which the selection of an ototoxic drug is necessary. So they've got some serious problem and they have to take the risk of maybe affecting their hearing loss. I think my uncle, who's had to take some pretty strong cancer drugs, has had that effect on his hearing, the ototoxicity. Meniere's disease is the result of sudden unilateral hearing loss, and then it's associated with dizziness and vertigo. So patients often report a roaring noise in their ear called tinnitus. So some people will describe it as kind of a ringing in the ear. That's tinnitus, this noise, and also can cause dizziness and also known as vertigo, nausea. Because of the onset of this problem, Meniere's disease, it often affects a person's ability to work or drive. I've had one bout with inner ear, or I think I hurt something inside my ear, and I was just dizzy and sick and couldn't drive, couldn't walk, and had to go to the doctor. It was pretty serious, but it was just one bout of it, so I don't think I had Meniere's disease. I think I just had a bout with tinnitus, but it's pretty powerful when it happens if you've ever had ear problems. So mixed hearing loss is a combination of the sensory neural and the conductive. So let's talk about how we would test and manage hearing disorders. So this is chapter 12 in your book. One way we test hearing is through an audiometer, and this is called pure tone testing. And this is where we would provide a tone at one frequency. And you know what a frequency is. We've just talked about that. And so this device generates acoustic signals at different frequencies, and it's used to assess a person's hearing. So human ears are capable of hearing sounds from 20 hertz to 20,000 hertz. So a pure tone audiometer is designed to generate sounds within the speech range. So we're going to test hearing at certain frequencies and certain decibels to see if a person can hear what's adequate for speech. And we might find what's known as their threshold of hearing. The threshold is described as the lowest possible intensity level at which a patient can correctly respond to a tone 50% of the time. Next, let's talk about air conduction audiometry and bone conduction audiometry. Air conduction testing typically involves the use of earphones or speakers to deliver the sound to one ear and then the other ear. So the person being tested wears headphones, and a person might say, the instructor might say, raise your hand or push the button when you think you hear the sound. As the intensity of the sound will continually decrease, the patient is encouraged to respond even when the signal is barely perceptible. The audiologist will plot the results of the air conduction test on what's called an audiogram. And there is a picture of this on page 258 of what a pure tone audiogram looks like. So an audiogram depicts the tested frequencies along a graph. There's a horizontal axis and a vertical axis. So the results of air conduction testing, you can see this being done in figure 12.2 on page 257, can reveal the presence or absence of problems within the auditory system. And then bone conduction audiometry uses pure tones just like air conduction. However, bone conduction bypasses the structures of outer and middle ear and only is assessing the inner ear. So the outer and middle ear are not to ear. We're just looking at the inner ear. So a person who may only be able to experience a conductive problem affecting either outer or middle should exhibit normal hearing sensitivity during bone conduction testing. So if they're having just outer or middle problems, bone conduction is not going to show that. So bone conduction testing involves the placement of a bone vibrator on the patient's forehead or mastoid bone, which is right on the ear. And this bone vibrator is placed on the skull, and a pure tone signal is generated. And so it's transmitting a signal directly to the cochlea. So this is how we're testing the inner ear. Speech audiometry is how an audiologist might determine if a person is understanding spoken language. So to determine the person's ability to understand speech, they'll complete two different speech tests. There's SRT, which is speech reception threshold, and a speech or word recognition
It's 10 o'clock.
test. As we discussed in the section on audiometers, a threshold is determined when a patient correctly responds 50% of the time to the signal being provided. During a speech recognition test, the audiologist is also interested in determining a threshold for the reception in speech. Acoustic emittance is described as the transmission of energy examined as a function of the resistance present within the middle ear, or the ability of the middle ear to allow sound to pass, which is acoustic admittance. As you might imagine, the presence of fluid in the middle ear or a perforated tympanic membrane is going to restrict the middle ear's ability to transmit sound. So this acoustic emittance is a way to test the transmission of this energy in the middle ear. So we can see if the tympanic membrane is functioning as it's supposed to. So to assess middle ear functioning, the audiologist uses what's called a tympanometer, and this test is referred to as tympanometry. So an airtight probe is placed in the ear canal, and the pressure in the ear canal is modified while a tone is introduced. The tympanic membrane responds to the tone, and then the changes in ear canal pressure, and these results are plotted on a graph or a tympanogram. And lastly, otoacoustic emissions, or OEAs, is another testing procedure, and this is a probe placed in the patient's ear and contains both a speaker for producing a rapid series of audible clicks and a microphone to capture the signal produced by the cochlea. Researchers discovered that in addition to spontaneous sounds produced by the cochlea, sounds could be evoked from the cochlea following acoustic stimulation. So OEAs have proved to be a significant innovation toward early identification of hearing loss, because the child or person receiving the OEA doesn't have to raise their hand or tell you that they heard anything. You're actually just testing the signal of the cochlea. So an audiologist is able to use the results to determine whether the cochlea of a child or adult is functioning normally. Although OEAs can provide information regarding the functioning of the cochlea, researchers are also interested in measuring the electrical activity that occurs when the signal reaches the acoustic nerve. So when an auditory stimulus is presented, we measure the electrical activity of the acoustic nerve and the brain. So they're measuring auditory evoked potentials. So it's very useful for assessing difficult to test patients in a coma, and newborns. And you can read more about this in your book. So hearing testing involves a number of specific diagnostic procedures. Air conduction testing provides information regarding the outer, middle, and inner ear pathway, whether they can hear sound transmitting. Should the audiologist determine that hearing loss is present, bone conduction testing can help bypass the outer and middle ear to assess functioning of the cochlea. Speech audiometry enables the audiologist to assess the person's ability to perceive speech. And then acoustic emittance testing helps the audiologist to determine the nature of the conductive hearing loss. And OEAs and auditory brain stem response testing are two very important tests to further assess the auditory system and are used to assess the hearing of newborns. There's also more information at the end of your book if you want to read more about hearing testing. So, how do we classify the results of these hearing tests? One method of classifying the results of hearing testing is to classify according to the degree of hearing loss. So, normal hearing ranges from below 10 dB to about 15 dB. You will observe that this classification system progresses from slight to mild and ends with profound hearing loss. So you can see that on page 265, and you can also see it here in front of you. So there's normal, mild, moderate, severe, profound. According to the Alexander Graham Bell Association for the Deaf and Hard of Hearing, deaf is defined as hearing loss, which is severe enough to make it hard for a person to understand speech through listening with or without hearing aids or cochlear implants. So when discussing hearing loss, you need to look at the time when hearing loss occurred, congenital, which is related to genetic factors and birth, and then acquired, which is anytime after birth. So when we look at treatment for people with hearing loss, we have two terms that we use: habilitation and rehabilitation. So rehab or rehabilitation is the restoration of a skill that has been lost. And habilitation is they will be taught speech and language skills for the first time. So let's look at some ways that we habilitate or rehabilitate, whether it's for the first time or whether we're rehabbing something that was lost. So amplification systems such as hearing aids are often used. So amplification means a signal is made louder. Most people get fitted today with a digital hearing aid. The hearing aid has a microphone, signal processor, digital to analog converter, analog to digital converter, and a receiver. So there's a lot of different types and styles of hearing aids. There's behind the ear, in the ear, open fit, completely in the canal hearing aids. There's a whole, if you look on page 268, there are examples of these different hearing aids. Also, there's a picture on 267 as well. So there's analog and digital hearing aids. And the digital hearing aid may be programmed by the audiologist to meet the needs of the patient in multiple acoustic settings. The digital hearing aid provides the audiologist with flexibility to program the aid according to the specific needs of the patient. So, for example, the author of this chapter, in chapter 12, on page 269, he talks about that his hearing aids have been programmed to maximize his hearing when he's delivering a lecture in an auditorium. So he can push a button and put the hearing aid back into auto mode, which will adjust the loudness and programming according to the level of noise and activity within his environment. So the patient and audiologist work close together to determine what's best. Analog hearing aids aren't really manufactured anymore, so digital hearing aids are primarily what's discussed in your textbook. The next device that we'll talk about is an FM system or an assisted listening device. And these are also amplification systems, and they use a broadcast signal similar to what you have with your radio. So it uses a frequency modulated wave, FM, just like an FM radio, to deliver the signal from a microphone to a receiver. So a lot of times in classrooms, a child may wear this system around their neck or have headphones on, and the teacher can wear the microphone, and the signal transmits directly to these headphones. By using an FM system, the teacher can often provide an auditory signal to the child without any distractions of classroom noise. So there's a greater opportunity for the child to be able to attend to what the teacher is saying. I have one student that is using an FM system right now in school that the FM system actually connects to their hearing aid. And so the teacher wears the microphone and it transmits directly to the child's hearing aid. At home, adults might purchase an infrared system that plugs into a television and sends a signal directly to the set of headphones. So in this manner, family members can watch TV at a comfortable loudness, and the person with the hearing loss can adjust their headphones so that they can hear at a comfortable level and it doesn't disturb anyone else. You also might notice sometimes these headsets are available in churches where people can wear them so they can hear the preacher directly and the other noise doesn't affect them. The next device we'll discuss is what's called a cochlear implant. For severe or profound deaf individuals, hearing aids and amplification devices are not going to have any benefit or very little benefit. So we now have what's called cochlear implants. And where a hearing aid will make a sound louder, and as you know, if there's a severe or sensory neural hearing loss, it's going to affect more than just the amplification of sound. It's going to affect their actual understanding of the sound. So this cochlear implant goes directly to the cochlea. It's a small electronic device and delivers an acoustic signal converted to an electric signal directly to the acoustic nerve in the cochlea. There's several components to the cochlear implant. There's external components, includes an ear level microphone, a speech processor, and a transmitter. They often look like a behind the ear hearing aid. And then the internal device components are surgically implanted, and they include a receiver that is placed behind the pinna under the skin and an electrode array that will distribute the signal. So when someone is fitted for a cochlear implant, the device will be turned on anywhere from 2 to 6 weeks following the surgery. It's not uncommon for the patient to initially experience headaches and have to go to an otolaryngologist or an ENT a week or so after the procedure. So you need to understand that a cochlear implant is not a switch that when turned on, the patient automatically understands hearing and speech. Because the acoustic nerve and brain are receiving signals in a manner that is not familiar, the patient will need extensive training in speech therapy to maximize the potential of the device. So it's not like automatically everything's understood, and so it's stimulating the cochlea and the nerve, but the patient still needs help understanding speech and language. For many hearing parents with congenitally deaf children, and then also adults who are later deafened, the cochlear implant seems to be like a miracle. Children are able to develop speech and language skills, parents are able to communicate with their children, etc. However, individuals in the deaf community have concerns and questions associated with cochlear implants, so it can be controversial. Do they really think it needs to change deaf people? They are a culture. The deaf community is a culture, and so they don't see themselves as disabled. So they see deafness as an integral part of who they are. So they don't really understand why someone would need a cochlear implant. So the primary language of the deaf community is American Sign Language. They use ASL, and so there is some controversy. So what is auditory training? Auditory training is a process that typically begins after an individual has been fitted with a hearing aid or cochlear implant. It's going to be directed toward the amount of residual hearing that a person has and their ability to use their hearing in a meaningful way. So speech reading or lip reading is a method encouraging the parents to focus in on the visual movements of the lips and jaws and tongue, in addition to body language and facial expression. This form of therapy is limited in the amount of help it can provide the client, because only about 30% of English sounds are visible. So a functional approach toward auditory training will focus on teaching the client to discriminate sounds that are confusing. So words that might be easily confused with speech versus non-speech or speech versus noise. So for example, a sound that might look like another sound, etc. So the speech language pathologist or audiologist might use visual cues, videotaping, mirrors, pictures, sensory clues, forming sounds in the mouth, feeling the larynx when it vibrates versus when it doesn't vibrate, so they can tell the difference between certain words and sounds. So then communication training can be thought of as two different groups, I guess. So one group is referred to as the oralist, and another group of individuals who believe that deaf children will never attain the necessary oral speech language skills to make them functional consider themselves manualists. So in oral communication, this oral approach emphasizes auditory training, speech reading, and written prompts to encourage the development of speech and language skills. The key to success in oral programs is consistency of practice. Manualist or manual communication involves using ASL or Signed Exact English. So you're using hand shapes, hand gestures, hand movements, body movements, sign language. And deaf community is often related to the individual's ability to sign rather than their loss of hearing. So I worked with the deaf and hard of hearing in California, and I was working on students' ability to voice or use speech, but I also felt like I needed to learn their language. So I actually learned ASL and learned sign language. So when I first started working with students, I didn't know it very well. They didn't have a lot of respect for me. But as I learned it, and about in the second year I was there, they realized that I really wanted to know the language. I was really learning the language. They accepted me more and more. I really felt like I was a part of the deaf community. But it's definitely a culture. So even though they accepted me, they didn't fully accept me because I wasn't deaf. So the difference between signed English and American sign language is that signed English follows the rules of English grammar. So you're actually speaking exactly as we talk. And then ASL is a language of its own and follows different grammatical rules. And so total communication is something that speech language pathologists, audiologists, educators often advocate because they feel like it's probably the most beneficial towards helping children with speech and language skills. Because with total communication, you're using sign language, but you're also using writing, gesturing, speech reading, oral speech. You're using everything you possibly can to help these children learn speech and language, which is what I used in California. So I used sign language, but I also believed in using the language of their peers in school and using written language that was appropriate for their classes. Because that can sometimes be a problem. The academic curriculum is they've got to write these essays, but if they're only using ASL, they're not going to know English grammar and be able to write appropriately, and that's going to affect their school. It's going to affect them with jobs. So total communication is often advocated for and can be very beneficial for academic development. Let's talk about the acoustics in the classroom for just a second. This is something that often gets overlooked by audiologists and speech language pathologists, and it's something that you need to be aware of and familiar with. If you look in your book, the very last part of your book on pages 276 through 279. And the two main things we look at when we're talking about acoustics in the classroom are signal to noise ratio and reverberation. Signal to noise ratio is the relationship between the speech signal and the amount of noise within the environment. So how much of what the teacher is saying in the classroom is actually going to the students, and then how much of it is affected by hearing loss within the actual students that have hearing loss, or the actual other noise that's going on in the classroom is affecting that signal going from the teacher to the student. Also, reverberation is a portion of the speech signal is not traveling directly to the listener because it's bouncing off the walls and ceiling and reaching the listener at a different time. So you've probably seen this in a large auditorium or in a gym where a recital or a production is taking place and the acoustics are terrible. And so there's this reverberation that's happening. I don't know if you've ever been to a concert in the Ryman Auditorium in Nashville. I used to live in Nashville, and the acoustics in the Ryman are phenomenal. So when a concert is happening on the stage, no matter where you sit in the Ryman, you can hear it in such a way. It's just very powerful. It's incredible. But then there's been other venues that I've been to where the acoustics are awful and you can't really hear it and it echoes, and it's not great acoustics. So for example, the gym that my church is in and has terrible acoustics. They've tried to do some things, put certain things on the walls and try to make it better, but you can hear that reverberation. So just be aware that that's that echo or that sound. It's called reverberation when there's not adequate acoustics within a facility. So some things that can be done are sound absorbing ceiling tiles, suspended ceilings, sound absorbing wall panels, which are actually used in my gym of my church. Noise in the classroom can come from air conditioning fans and gaps between the doors and door frames. So if those can be fixed, carpet can be used. Sometimes it can be too expensive, so people aren't able to do that. So sometimes it might just be positioning of the teacher or changing where the desk and tables are or putting a loudspeaker in the room or the teacher using an FM system like we discussed earlier. So just be aware of acoustics in a classroom or in an environment and how that can affect hearing. I encourage you to read these two chapters, chapter 11 and 12, so you can fully understand hearing and hearing disorders. I also encourage you to read the article on auditory processing disorder in your module, because I didn't talk about that here, and it's definitely something you should be aware of as a potential SLP or audiologist. I hope you've enjoyed this section on hearing and hearing disorders. Thanks.